Good morning, everyone. And I will be talking on the mechanism of resistance to osimertinib in the EGFR mutated lung cancer. We had back-to-back 3 talks on the use of TKI plus something on this. So we know what an osimertinib is, and it was approved in 2018 as the first-line therapy for advanced non-small cell EGFR mutated non-small cell lung cancer. But what happens is the patients inevitably develop resistance with no further clear-cut therapeutic options to date other than chemotherapy or local ablative therapies for selected individuals. So despite the success of osimertinib both in the first-line treatment setting and in the as a salvage therapy in presence of a T790 mutation, acquired resistance inevitably occurs in similar to patients treated both in first-line and in the second generation TKIs, thus limiting a prolonged clinical benefit, which has been achieved with this compound. So why does the resistance occurs to osimertinib? Because of the molecular heterogeneity of the non-small cell, which substantially influences the possible mechanisms of resistance to osimertinib. This contributes to a wide spectrum of the resistance aberrations which has been discovered so far. Along with that, multiple coexisting molecular alterations has also been observed in a considerable percentage of patients, both when osimertinib was used as a first-line therapy and also in post-failure of the previous EGFR therapies. So acquired resistance mechanisms of EGFR TKI can be broadly divided into EGFR dependent mechanisms and EGFR independent mechanisms. So this is a tabular format of the resistance mechanisms which we see with both the first line use of osimertinib and the second line use of osimertinib. So what we see that in both the settings, around 40 to 50% of the resistance mechanisms were unknown in both these subsets, whether it was used in first line or in the second line. Now confirming in the first line setting, what we see that around 15% of the patients in the first line had a transformation in the form of a small cell or a squamous cell transformation, whereas with the use of second line osimertinib, around 15% of the patients again had a transformation also. So this was one of the major part which we saw. Another thing is which we see that in the first line use of this, we see a second resistance mechanism around 6 to 10%, where either it was an EGFR amplification or it was a C797X or L718Q. These are the mechanisms, acquired EGFR mutations which we see. Whereas with the use of second line osimertinib, also we see that majority of these patients had a C797X along with EGFR mutations, or a tertiary EGFR, other tertiary mutations were also seen. Another subset which we see with the use of, mostly with the use of first line and the second line, is MET amplifications and HER2 amplifications in around 15% of the patients, whereas in the second line use of osimertinib, around 50% of the patients had a MET amplifications. This is one of the things which we see. Other than this, we have some fusions, cyclin D amplifications. These are the other mechanisms of resistance which we saw with the use of first line and second line osimertinib. These are the mechanisms of EGFR mutations, amplifications, and the bypass signaling activation pathways, mostly by the RAS-RAF pathway, the PIK3CA pathway, and the JAK-STAT pathway, which leads to this resistance mechanisms. And next comes the transformation also, which epidermal mesenchymal transformation, leading to this transformation to a small cell or a squamous cell. So a short detail in the different mechanisms. One of them, the EGFR dependent mechanisms of resistance. The T790M loss, which we saw in around 50 to 60% of the patients treated with first generation or a second generation TKI. The somatic mutation of resistance with a T790 develops, resulting from a gatekeeper mutation in the exon 20 of the EGFR, and it causes steric hindrance of the binding to their connected ATP binding site, leading to the development of resistance. And next comes the C797X mutation in EGFR mutated T790M patients. Second line treatment with osimertinib can lead to the emergence of so-called a triple mutant. That means with this double along with this C797X, it's a triple mutant. The most common tertiary EGFR mutation is a point mutation in the C797X, which accounts for around 15 to 25% of the cases of resistance to second line osimertinib treatment. See, other tertiary mutations are in exon 18, we have a mutation in L718Q. Residue interacts directly with osimertinib in the EGFR kinase domain of the ATP binding site. The G724S mutation has been outlined as a resistance mechanism to second-line osimertinib. In exon 20 also we see that the G796R/D and L792 mutations were anecdotally reported in NSCLC treated patients with osimertinib, and double mutant with T790 along with M766Q are resistant to osimertinib. Next comes the EGFR independent mechanisms, which we see are mostly the amplifications. The MET amplification, which is one of the most common mechanisms of acquired resistance to osimertinib, with a prevalence of around 19% in the first line use and 15% patients in the second line use. Next comes the HER2 amplifications. It also was detected in 5% patients and 2% of the cases. And HER2 amplification is mutually exclusive with a T790M mutation. And HER2 amplification resistance was sensitive to osimertinib plus an ADC with anti-HER2 TDM1 in preclinical models. Next comes the RAS and MAP kinase pathway mutations. The KRAS mutation or amplification and NRAS, MEK1 and BRAF mutations have all been reported as acquired resistance to osimertinib in 3% of the patients were first line use and 1% of the patients who progressed on second line. So BRAF mutation was found in around 3% of the cases with or without 790, both in first and second line use of osimertinib. Next comes the PIK3 pathway mutations, either via a PIK3 mutation analysis or a PTEN deletion. It was involved in around 10% of the patients who progressed on osimertinib. Next comes the fusions, which we saw that the FGFR3, the RET, the NTRK, these chromosomal rearrangements involving the driver oncogenes, namely the fusions, have been identified mostly with the use of second line use of osimertinib in around 5% of the patients. Next comes the cell cycle alterations. The plasma analysis of the study in the AURA and the FLORA study found that 10% of the resistance mutations in the first line osimertinib and 12% in second line osimertinib were represented by alterations in the cell cycle related genes. This includes the amplifications or mutations in the cyclin D1, 2 and E1 genes and the CDK4/6 and CDK4/6 genes. And most importantly, what we saw that the histological transformation, the histologic conversion from EGFR mutated into a small cell or a squamous cell has been reported in around 15% of the patients. Notably, the risk of small cell transformation has been significantly associated with contemporary presence of RB1 or a T53 mutations, while no small cell lung cancer were recorded in the wild type patients. So the therapeutic strategies to overcome this osimertinib resistance, despite the promising results obtained from the osimertinib in advanced patients with non-small cell, resistance ultimately develops due to treatment selection pressure and inherent heterogeneity in the tumor cells. The intra-patient heterogeneity and the co-occurrence of multiple resistance mutations constitutes a major challenge in developing an efficient treatment strategy to counteract this tumor progression. So remarkably, the clonal evaluation of the oncogene-addicted non-small cell lung cancer can give rise to different molecular aberrations both in space, that means between the primary tumor and the metastasis, and in time, that means after a treatment failure, contributing to a complexity of the molecular resistance machinery. So what are the treatment strategies which has been used? One of them is the combination of chemotherapy along with osimertinib or the other agents also, which we saw in the previous talk. Also the use of VEGF inhibitors like the bevacizumab and the ramucirumab along with the TKIs. The combination with some first generation TKI also has been reported in some studies. The alternate pathway inhibitors like the amivantamab lazertinib combination or any other combinations which are on these studies. And lastly, the immunotherapy combinations also which we see. These are some of the trials which are on still in trial phase. The different drug combinations like the etoposide carboplatin along with osimertinib, the osimertinib plus geftinib. We have all these. This busy slide. We have the combinations in. These are on this trial phase. So the resistance mechanisms and the therapies. So concurrence of more than one mutations. We need a good combining effective TKI when it's tolerable, but chemotherapy and ICI or anti-angiogenic therapy, these are immunotherapeutic options are not the first choice in these, because we know that when there is a driver mutation, we need to treat the with the anti-driver mutation drug first, and some rare or unclear mutations and circumstances are not listed which might be affecting this. So the resistance mechanism which has been seen is one of them is the T790, the amplifications and the transformations. So the conclusions are the optimal subsequent treatment after progression to osimertinib must be tailored according to the sites of progression and the resistance mechanisms. To date, for assessing the osimertinib resistance mechanism, the gold standard remains a tissue rebiopsy, which allows a histological evaluation also, and an NGS and an RNA-based fusion panel analysis. If tissue biopsy is not feasible, the ctDNA analysis or a liquid biopsy can be assessed. In patients with limited progression sites, either in the brain or other organs, data supports the use beyond progression of osimertinib treatment with definitive local therapy such as stereotactic radiotherapy or surgery to the sites of oligoprogression. And in patients requiring a change in systemic therapy, although the standard of treatment is still platinum-based chemotherapy, strategies targeting the specific resistance mechanisms are showing promising results, and they should be encouraging access to clinical trials with specific agents targeted at the resistance alterations. So with this, I think I end my talk.